Well, thank you. It's a pleasure to talk to you today about fungal diagnostics in the immunocompromised patient. I appreciate the opportunity to speak with you and hope to share some useful information as it relates to an area that we really need to make progress in this for quite some time. And it's good to see that we're finally moving in the right direction. My disclosures are listed here. And what I'd like to cover today is some diagnostics as they pertain to the following pathogens. And this is the order in which I will go. Aspergillus and other molds, Candida species, Cryptococcus, and the endemic fungi, including Histoplasma, Blastomyces, and Coccidioidomycosis. I will not cover Pneumocystis today. So, with respect to Aspergillus and the other molds, most of us know that there are fundamentally three non-culture based diagnostics, and they include the Aspergillus galactomannan of both serum and VAL, the Aspergillus PCR for serum and VAL, and then the non-specific test, the 1,3-beta-D-glucan, which is more of a pan-fungal marker, but is oftentimes usually positive in the face of invasive aspergillosis. As you kind of look at the diagnosis of Aspergillus, of course, there are the direct tests, which are direct microscopy, culture, and cytology, but really going to focus on these indirect tests as I've listed below. And the lateral flow assay listed at the bottom is the newest of these diagnostics, and it's still based on the galactomannan, but it's a rapid, non-quantitative test that we're using more and more. Galactomannan kinetics are important to understand, and these and this marker is basically, it's a positivity suggests hyphal growth, and it's a reflection of fungal burden when it is quantitated. It is important to understand that the galactomannan assay was developed, the Aspergillus galactomannan assay was developed for patients with hematologic malignancies and allogeneic transplant recipients. So it was validated in that population, but it's been used and applied to patients with all sorts of underlying conditions. But it's important to recognize that the galactomannan performance, most of its published performance, has been in individuals with extreme immunosuppression. That is, patients with neutropenia, allogeneic transplant recipients, and others with hematologic malignancies. Important to know that levels are influenced by renal and hepatic function. They can be artificially elevated. And for patients who are receiving antifungal prophylaxis or exposure to antifungals under any circumstances, these levels can decline. And so, as I've alluded to, if one applies this test to individuals who fall into other categories, such as solid organ malignancies, solid organ transplant, patients on steroids or biologics for other conditions such as rheumatologic diseases, sarcoidosis, its performance is really less reliable, and we're not entirely certain what a positive or a negative assay means in that setting. You can follow the galactomannan serially in patients who do have established disease and follow it as a response to therapy, although it is not validated for that purpose. The ELISA, most of you are somewhat familiar with how the ELISA works, but you do have to have an optical reader to perform this assay. Important to recognize that and what I'm taking here are meta-analyses looking at both serum and then BAL as in terms of its performance characteristics. And if one looks at in the table 1, optical density or the cutoffs of 0.5, 1.0, 1.5, sensitivity and specificity really improve as that optical density goes up. Now, with the BAL, which is in table 2, looking at the same cutoffs, except there's also a 2.0, which is really quite high. You can see that the sensitivity and specificity, they range, they probably perform a little bit better than they do in the serum. Positive and negative predictive values are provided as well. And then, of course, individuals who are getting antifungal therapy or prophylaxis is included here as well. The point here being that these tests really do perform quite well in patients with hematologic malignancy, stem cell transplants, less well in solid organ transplants, less well in people who are receiving antifungal therapy or prophylaxis. Given a positive or a negative test, you always have to interpret in light of the particular population, the particular patient, in order for it to be a really useful assay. Now, the lateral flow assay is something that's been relatively recent in development. It also measures galactomannan, at least the one that is most commonly used. It's a point of care rapid assay. It can be performed in about an hour, and it can be performed on serum or BAL. And it does measure galactomannan. Its sensitivity and specificity in serum and BAL are, as depicted here, 97, 98% for serum and 91, 92% for BAL. Its negative predictive value is 99%. The downside of a lateral flow assay, and why it's probably not used a lot more, is that it's not quantitative. It's simply a positive or a negative result, and you don't get a quantitative value as depicted here. So you get a positive reaction or a negative reaction, but it's not quantitative like the traditional galactomannan by ELISA. Now, if one looks at these assays, though, and compares them, and again, the 1,3-beta-D-glucan is used, and it can be used for this, but it's completely non-specific. There's a lot of cross-reactivity, certainly with the VDG and the galactomannan, much less so the lateral flow device. Other compounds, typically antibiotics, can cause false positives. Any of the beta-lactam antibiotics can do so for the beta-D-glucan or galactomannan, doxycycline for the lateral flow. False negative results, generally with concomitant use of antifungal therapy. But this gives you kind of a comparative performance of these assays. And then the PCR, the last of these, it's only commercially available in Europe, not in the US. It's in the US and in many parts of the world, it's basically a local formula. Most people have looked at serum PCR, but it's also used in BAL. its performance entirely dependent on technology, cycle thresholds, and other targets. Recent meta-analyses suggest that its sensitivity and specificity is 84 and 76% respectively, which is similar to the galactomannan, Aspergillus galactomannan, with 2 positive results. The sensitivity drops to 64%, but the specificity improves dramatically. A quantitative PCR, which is done in the serum, can at the beginning or at the time of diagnosis, can correlate with 3-month mortality, and so it's useful for that. But following it serially has not been useful in following response to therapy. So why this is important is they have to be plugged into these recently revised definitions. And so when the EORTC-MSG revised definitions for mold disease, I think are the most complex, because you have to have, of course, proven is easy. That's a biopsy or a culture from a normally sterile site demonstrating the appropriate organism. But for patients with probable disease, you have to have the host criteria, which are listed here, and the clinical features, which are in the column on your right. And that includes radiographic features as well. So I'll show you those in a minute. But then that's coupled with mycologic evidence. So the 3 components: host factors, clinical and radiographic findings, and mycologic evidence. And the mycologic evidence can be culture, or it can be PCR, or it can be galactomannan. And the cutoff for a single specimen is 1.0. Multiple specimens are acceptable at cutoffs that are lower than that. And of course, a positive culture in this patient is good evidence for probable disease, but not proven unless it's from a sterile site. And it needs to be coupled, remember, with films that are compatible with the diagnosis, such as this one, showing a cavitary lesion in the left upper lobe. Okay, moving on quickly to non-Aspergillus moles. There is very little to report here. Serum PCR for Mucorales is the only thing that's actually being developed at this point. There is a quantitative PCR for Mucorales that is being tested, but really nothing more than that at this point. So for Scedosporium, Fusarium, some of the other non-Aspergillus moles, we simply don't have much to report here. There are tissue-based PCR assays available, and those are sent at our university. We send these to the University of Washington, and they will amplify tissue that's sent, but they're really most helpful if the fungal stains are positive and the cultures are negative. Sending specimens where the fungal stains are negative are just much less useful. I should mention again that 1,3-beta-D-glucan can be positive for many of these agents, but not Mucorales. Mucorales generally are negative for 1,3-beta-D-glucan. For Canada, moving on to Canada quickly, we kind of break these down into 2 categories. One are the culture-based, and then the non-culture-based. So for the culture-based, what's new in culture-based diagnosis is not the blood culture itself. The blood culture has always been insensitive and it's time inefficient. It really depends on the load of yeast in circulating blood, much slower, of course, and the sensitivity is much lower when there are fewer than 10 cells per bottle compared to over 1,000 yeast cells per bottle. But I think that when one does grow it, if one has the current technology using MALDI-TOF, for instance, you can take these organisms that are growing on solid media and within 10 to 15 minutes have an identity using essentially mass spectrometry through the MALDI-TOF mechanism. It's a mechanized version of doing this. But alternatives to this include the BioFire, which is direct from blood culture. Again, the GenMark, Accelerate, and PNA Fish. But again, all of these require the organism to be growing on solid media. So these are time inefficient as these things go. And so alternatives to this are really important. And so we have several culture independent diagnostic tests for invasive candidiasis, and they include, of course, the 1,3-beta-D-glucan. It's reasonably sensitive but not specific. The problem here is a very slow turnaround. It's usually a send out, so 24, 48 hours. And that's a long time for patients with invasive candidiasis or candidemia. PCR can be quite sensitive and specific, but there again, most of these are sends outs and therefore quite slow and just not really very helpful in the acute setting. The T2 Candida, however, can detect Candida-specific DNA from whole blood obtained at the bedside. It can be run within 3 to 5 hours, and its sensitivity and specificity are actually quite acceptable. The problem is it's really expensive. In the US, this costs about $125 per assay. And so it's really something that I think can be cost prohibitive for a lot of centers. And its sensitivity and specificity are not perfect by any means, even though it's DNA based. These tests all perform best when your prevalence of the disease is higher. And so really the pretest probability is very important. And so these tests perform best in blood cultures when the pretest probability is kind of between the 3 and 10% rate. In other words, a good likelihood of having the disease, whereas in patients in whom the disease is unlikely, these tests are not terribly useful. And the same is true for invasive candidiasis or intra-abdominal candidiasis. Here, the sweet spot is again probably somewhere between 5 and 20%. Much lower than that or much higher than that, and the tests really deteriorate in terms of their ability to be predictive. Finally, I want to say a couple of words about markers for cryptococcosis. The cryptococcal antigen, I think, remains one of the most predictive and valuable rapid assays. I think that what has changed is that the LFA, this lateral flow assay, has really revolutionized how we diagnose cryptococcosis. It's quite efficient. Performance characteristics are excellent, and it can be turned around in about 15 or 20 minutes. Outside of that, what's used, I think, in cryptococcosis that's useful is the EFA, early fungicidal activity. This is a measure of the quantitative clearance of yeast from the CSF, and it's useful for phase 2 and phase 3 clinical trials, and it correlates with improved survival. So a more rapid clearance correlates with survival. A slower clearance survival is poor. Some of the newer technologies, including BioFire and the BDG, are not very reliable for diagnosis, and so we're not really using these very often. Just to show what the EFA looks like and how this correlates, on the bottom panel you can see 3 graphs, and the middle graph shows how rapid clearance with the combination of amphotericin and 5-FC correlates with the best survival in the Kaplan-Meier graph above. And this is just another clinical trial showing that these different regimens led to similar clearance and therefore similar responses to therapy. Finally, I want to talk very briefly about non-culture-based diagnostics for the endemics. And there's really not a lot new to report here, but just simply to remind you that the histo, urine, and serum antigen detection is really quite sensitive and specific. It's also validated as a means to follow response to therapy. For blasto, much less so, simply because of significant cross-reactivity with the histoantigen. There are new methodologies for the coccidioidomycosis diagnosis. The confident fixation and immunodiffusion are older therapies. There is new cocci-antigen testing from the urine that's really quite good and a very good way to rapidly diagnose and to follow patients on therapy. So not a lot to report with the endemics except for the newly available cocci-antigen testing. So if I were to grade these, I would say with Aspergillus, we're probably at a B. We still lack sensitive tools for early diagnosis and validated response to therapy. So you can't really know using these assays when a patient is cured or not. I give it a B. For the other moles, Mucorales, notwithstanding, not much progress. I give it a C. For Canada, for all the activity and for the huge burden of disease that we have, we still don't have truly reliable and rapid turnaround assays from serum and blood, nor do we have reliable markers for non-candidemic infection, nor do we have markers to determine response to therapy. I give it a C. For crypto, I think it probably is the standard, an A minus for crypto. And then for the endemic mycosis, give it a B plus. Excellent rapid diagnostic tools, but no valid means to follow response to therapy. So with that, I will conclude and thank you very much for your attention. Look forward to any questions that you may have. Thank you very much.